Bismillahirrahmanirrahim. Assalamualaikum and good morning. Young Bormat, Dr. Lee Boon Chai, ladies and gentlemen, welcome to this forum on the value-based healthcare as well as patient-centered care. Well, first I'd like to thank the organizers for inviting me to this forum. It's a pleasure to be here. And I think we are in for a very interesting day. I've got three panelists here. As you've heard, Dr. Izzuna Mudla is a public health specialist. She's in charge of the Health Technology Assessment Division in the Ministry of Health. It's a very important division. I just wish that the rest of the ministry will listen to the advice before they introduce new technology. Got Dr. Milton Lam, a very senior and distinguished obstetrician and gynaecologist. He's been past president of the MMA, very active in professional societies, and he writes a column regularly in one of the dailies. We also have Dato, Dr. Kuljit Singh. He's an ENT specialist, but he's also the president of the Association of Private Hospitals, Malaysia. Can I have my slides? Okay, when we talk about value and we talk about patient-centered care, these are two fairly complex things. And I'll try very briefly in a couple of minutes just to give a couple of highlights. Let's look at the concept of value. You've got to look at it from the perspective of the different groups, of the patient, the people who pay for the care, as well as for the provider, as well as from the perspective of the community. If you look at some initiatives around the world, there's an interesting one in the state of Vermont in the USA. Vermont is a very small state. And unlike the other states in the US, they put in a new system with a global budget. And they were trying to get value. And they're going for no-fault insurance in the state of Vermont. Very interesting. New Zealand has it. So we need to look at what's happening in the state of Vermont. It's a small state of about 3-4 million population. I think we'll probably get some reports coming from there in the policy literature soon. There's also another initiative in France. I hope Napier, they're involved in IT, should know about it. In France, you have the lifetime health record on a card. You see, Malaysia, 20 years ago, under the telehealth blueprint, one of the pilots was the lifetime health record. Don't know what's happened to it now. But France had the card Vitale. The patient's record is on the card. When the patient sees a doctor, the doctor looks at the patient's health record. The transaction is recorded into the card. The patient makes a co-payment without having to apply for reimbursement by the patient or by the healthcare provider. Within 2 weeks, the patient receives reimbursement minus the co-payment without having to apply for it. And the doctor receives his payment within 1 month without having to apply for it, just using their card. So it cut down administrative cost. Now that's value. And for the patient and provider, convenience, so it is effective. Jamie Dimon from JP Morgan, Jeff Bezos from Amazon, and Warren Buffett are collaborating together to look at the health of their employees, together 1 million of them. They are trying to look at how are they going to do to handle the insurance side for the population of 1 million. So they're starting small. There's a website on it. Please look up on what the initiatives are. And what does Warren Buffett say? Healthcare should be not for profit. Coming from Warren Buffett. Very interesting. So I think we should look at it. Now, if you want to look at value on what we're talking, have a look at this book. There's a book called Redefining Healthcare by Michael Porter and Theisberg. It was published by Harvard Business School in 2006. I think the concept of outcomes and the framework of outcomes and the concept of values and how we shall measure it is very well laid out in readable form by Michael Porter and Ira Tisberg. If we look at value, I've been a patient. Many of you have been patient. Did you get value or not? My God, I spent 5 hours at IJN. What is the opportunity cost? How much should I charge IJN per hour for spending to wait for the care there? Is it fair to look at it that way? Well, as a patient, you may want to look at it that way. If I were to buy a car, let's say a Proton, it costs 80,000 ringgit, right? All Protons cost 80,000 ringgit. I'm guaranteed that it will last. I'm guaranteed this and that and that. And I know that every Proton is the same. Now, I get appendectomy. I go to one of these hospitals. If I'm lucky, I come out in 3 days after the operation. I pay 10,000 ringgit. I recover at home for 1 week. And maybe 10 days' time, I'm back at work. Very good. Malaysia actually has good healthcare. And it's affordable compared to this region. But then if I'm unlucky for the same appendix, I spend 5 days in ICU, 2 weeks in hospital, 2 weeks to recover, and it cost me 100,000 ringgit. Hey, here I get the same operation, I suffer more, I'm sick longer, and on top of that, I got to pay 100,000 ringgit. What's this? Is that value? Well, can everybody who undergoes appendectomy pay 10,000 or maybe not 10,000 lah? Got to look to capture in the cost of complication for that 5 or 6% of patients. Maybe 11 or 12,000 ringgit. Everybody pays 11, 12,000 ringgit as a guarantee. Can we have that? Well, I think when we talk about value, that's one of the aspects that from the patient perspective, they want some guarantees. Is it realistic or not? Well, people are working at it. Some of these issues about packaging, bundling of payments, that's what it's all about. And as well as that, the outcomes in terms of the experience, in terms of the clinical outcome and the functional outcome. So value then is measured based on the outcome as well as the care that's been provided. If you take this approach, then theoretically, patients will spend less, they're more consistent with the health outcomes, and they get greater satisfaction. For the providers, hopefully, people will trust them more, they will be more efficient with better quality. For the funders, the cost can be more predictable, and hopefully it can cost less. And for the community, the health status is improved. What actually am I talking about? What I'm talking about is, can we put the incentives in the right place? The incentive is to focus on patient getting better, reduce unnecessary care. And there's a lot of over-servicing and over-utilization in all healthcare systems, including ours. There's an interesting thing. New Zealand is taking the approach of the triple aim of IHI. The triple aim: look at cost, look at health, and look at care. I don't have time to talk about it, but you can ask questions later on about it. So, one model of trying to integrate care, so the care is continuous, coordinated, integrated, seamless, irrespective of time and geography. And in a way, that's what Minister was talking about just now. To empower people to make good decisions about their care, about their own health, about their lifestyle. These patient-centered medical homes was started in the US 15, 20 years ago. It does not have to be a physical facility. It can be virtual if the electronic health record are shared. So, at this patient-centered home, the doctor, the nurses, all the other healthcare providers, all the welfare support from the community, all the NGOs work together with the patient and the family in the delivery of care. I was told that Singapore is starting a model. Our health center actually can be a model, can be a platform to build this on. And I think this is something that we need to look at. So, the future is taking the value-based approach, and please expect resistance from the doctors, from the hospital. Expect resistance. But so what? They will resist change anyway. We want to go towards digital health, digital medicine. No, we got to drag the doctors and the hospitals screaming into the future. And hopefully we can move from fee-for-service to fee-for-value. And that's what I hope we are talking about, a lot of it today. So now I'll invite the first speaker, the lady. We are gentlemen. The lady comes first.
Thank you, Tan Singh, Dr. Abu Bakar Suleiman. Yang berhormat Dr. Lee Boon Chye, Deputy Minister of Health, Dr. Milton Lam, Datuk Dr. Kuljit, ladies and gentlemen. In healthcare, decision-making is always a complex, overwhelming and challenging things to do, since the needs, the expectations towards healthcare is very demanding and the resources are always finite. Having said so, the ultimate goal of any healthcare system is to improve the values of patients. Okay? This is why the value-based care is considered as the future of healthcare. Value-based care is not a term that just popped up. It evolved from evidence-based medicine, which has become the prevailing medical paradigm in the 1990s. Evidence-based medicine as defined by Sackett et al., is the conscientious, explicit judicious use of the best available evidence to make decisions on individual patient care. And the definition has been expanded not only on individual patients but also to groups of patients and also in policy of healthcare. In the pre-EBM eras, there is no requirement to adhere to scientific evidence. However, in the evidence-based era, the emphasis is given on adherence to scientific evidence. This is when health technology assessment has been established in many countries, especially in the developed nation. And also, evidence-based clinical practice guidelines being developed to reduce variations in healthcare and also to improve the quality of care. Value-based medicine was first started by a team, Dr. Brown and his team, at the Center for Value-Based Care at University of Pennsylvania. So they define value-based medicine as the practice of medicine incorporating the highest level of evidence data with the patient's perceived value conferred by healthcare interventions for the resources expended. There are three things in the definitions that should be highlighted. First is the usage of the best level of evidence, which is similar to evidence-based medicine, and the patient perceived value, which is converted in terms of utility value, which is measurable, and the cost utility expected by selecting the treatment options. Okay, value-based healthcare, as mentioned, is a holistic approach in managing patients, where patients is at the center of care. Okay. It used the best available evidence to ensure better patient's outcome and include patient's value in the utility. Utilizing value-based healthcare will not only reduce costs to the healthcare system, but also will increase patient satisfaction, improve quality and outcomes, and also it allows information sharing, where this cost utility can be compared between the different treatment options to make objective decision makings. Government agencies, academics, and certain private agencies has conducted systematic approach to apply this value-based concept. For example, health technology assessment is the systematic process of health technology evaluations which provide the stakeholders with value-based information for decisions. Horizon scanning is the systematic process of identifying new and emerging technologies and also innovations in healthcare which have highest potential in terms of clinical outcomes, organizational, societal, ethical, and also cost. Okay? This will provide information for future planning of the healthcare system to ensure that the decision made is based on evidence and also value. Both the health technology assessment, horizon scanning, and also clinical practice guidelines are provided by the Malaysian Health Technology Assessment Section to provide input to the Ministry of Health in making decisions on healthcare. Clinical practice guidelines provide the current and evidence-based recommendations for practice in managing patients. So it reduces variations in care and actually reduce costs in managing patients as well. Okay, some of you may come across different terms such as evidence-based medicine, comparative research, and also health technology assessment. So let us look at the relationship between evidence-based medicine, comparative research, and HTA. Okay, when there's a new technologies, okay, when you have the technologies, you want to know whether can this technology work. So this is a question on the evidence, whether there is evidence on efficacy, is quality as well. Okay, and then you want to know, does it work? This is when evidence-based medicine plays a role. Okay, evidence-based medicine look at evidence. Try to find the best available evidence by searching and appraising the literatures. Whereas comparative effectiveness research is being used differently by different groups. Most of the times, it's usually refer to the head-to-head clinical trial, and usually it's pragmatic trial to look at the effectiveness of certain technologies. So this cost-effectiveness research and evidence-based medicine actually looks at the best evidence to provide information for decisions. HTA goes beyond EBM, where it looks into other values that is not available in clinical research sometimes. It takes into account patient satisfaction, patient's value, the organizational, societal, and also ethical impact of certain technologies if it's been introduced into the healthcare system. Okay, health technology assessment provide input for coverage decision making, and it also being used for procurement decision, price negotiation, and also for clinical practice, where it provide input for clinical guidelines. Okay, in certain countries they have a program which is known as coverage with evidence development. Sometimes it's a new technology, not much evidence available, but the technology is safe, so they allow the technology to be in the market and being used. But at the same time, it's a necessity to get information, to get data on the use of the technologies to see whether there's any safety issues or other usage of the technologies. If there is any issues, the technology can be taken out from the system based on this data. So this allow evidence development again. Okay, there is the relationship between EBM, computer research, and HTA. Okay, when we talk about values, what are the elements included in values? Okay, the purple or the darker box is the traditional values being measured in, the traditional elements being included in the value, which include the life years gain, improvement in quality, cost saving within health system, productivity and cost savings outside health system. Sometimes productivity is quite difficult to assess. Yeah? Okay, these are measurables, and which elements to be included will depend on which perspective you are assessing, either as a provider, healthcare providers, as payer, or as the government, or as societal perspective. So it depends which perspective you are looking at. Okay, and there are other elements that has been proposed to be included in the value, which include scientific spillover, insurance value, real option value, value of hope, and reduction in certainties. These things are not that easy to be measured, and most of the time not included so far. Okay, there are several steps taken in applying value-based healthcare. There are 4 steps. The first step is asking and answerable questions. Usually we use PICO concept, which is the population, intervention, comparators, and outcome. Okay, so when we have the answerable question, then we search for the best available evidence and appraise the evidence. This is similar with evidence-based medicine steps. Okay. So from the step 2, you will know whether there is enough evidence, whether economics evaluations is feasible or not, and whether you can get the data to conduct economic evaluation, and whether you have to conduct economic evaluation or not. Okay. Then the step 3 is the center of value-based healthcare, which is a cost-utility analysis. Okay, you measure the utility value, calculate the total value, estimate the cost, and calculate the cost-utility ratios. The last step, is when you conduct a sensitivity analysis to estimate the uncertainties, to reduce the uncertainties, so that you can make proper recommendation based on the data. You can interpret the data correctly if there's changes in the values. Okay, this is an example how value-based care has been applied. Okay, where WHO has recommended as strategies in non-communicable disease. Communicable disease is to invest in the prevention and control, where evidence have showed that investing in prevention and control of NCDs not only will improve longevity, improve life years gain, it also increase productivity and increase the country's economy. Okay, and WHO for the first time has come out for best buys. Okay, for best buys in 6 areas, 3 on the disease areas and 3 to tackle the risk factors. Okay, for example, in tackling NCDs, the best buys, when you invest $1, the return of investment is $7. Okay, if you that is for prevention of tobacco use. Okay, and if you invest in unhealthy diet, $1 in unhealthy diet, the return of investment is 12 USD, which means that you pay $1, you gain $12, which is a good return of investment. Okay, this is return on investment study, which actually evaluate the value of the interventions, public health interventions. Okay. As a conclusion, value-based medicines incorporate the highest level of evidence data for quality of care. Patients' perceived outcomes of value is the one that matter most, and by prioritizing the options using the maximum utility per cost, this facilitates an efficient allocation of resources and objective decision-making process. With that, I thank you.
Thank you very much. Can I invite now Dr. Milton Lam for his presentation? If you've got questions, can you please write down the questions so that you don't forget it when we come to question time?
YB, Tan Sri, ladies and gentlemen. There's a movement. Gosh, I hope you can read it. What I have to say doesn't reflect that of any organization that I'm associated with. So these are personal views. Okay, I shall confine myself to the second half of the topic, which is putting the patient at the center of healthcare. I think we all are aware of the challenges that are facing the healthcare system all over the world. Now, people have moved from the concept of volume to value. And basically what people are looking at is cost reduction, getting value for money, and there are currently attempts at diagnostic assessments of various healthcare systems to remove the waste, the harm, and the variation, and the prioritization of most impactful interventions. You don't have to copy this because the soft copy of the presentation has been made available to the organizers. You can get it from them afterwards. Now, I'd like to comment to you the mental models where volume has shifted to value. People have talked less about patient satisfaction and more about the patient experience. And people have also begun to move from hospital setting to community setting. Now, when we put a patient at the heart of healthcare, we are actually putting the patient and the family at the heart of every decision and empowering them to be genuine partners in their care. The mental model has to shift from what is the matter with you to what matters to you. The former focuses on the disease condition, the latter on the person. And I'd like to remind ourselves what one physician said 2 millennia ago, and that it's more important to know what sort of person has a disease rather than to know what disease a person has. So when we talk about person-centeredness, I think we have to be consistently person-centered in word and deed. I always say talk is cheap, so we have to match what we say with action. Now, the concept is not new. The WHO Western Pacific region, of which Malaysia is a member, published its document People-Centered Healthcare way back in 2007, more than a decade ago. And they looked at the weaknesses in health systems, and they're all listed down there. They had 3 objectives in their vision for people-centered healthcare. 1 is a culture of care and communication. 2, responsible, responsive, and accountable services and institutions, and supportive healthcare environments. They then made recommendations for areas of reform with regard to individuals, families, and communities, health practitioners, healthcare organizations. And these are the proposals, summary of their proposals for individuals, families, and communities, for health practitioners, for healthcare organizations, and for healthcare systems. Now, I would like to put it across to you that leadership is essential in all these matters. And I'd like to commend to you an article from the Institute of Healthcare Improvement in Boston, Massachusetts, on high-impact leadership, improved care, improve the health of populations, and reduce costs. The 3 objectives of the Triple Aim. This slide, I think, sums it all up. You put the patient at the center of healthcare. Then you have community participation. You have a vision. And then you have defined the outcomes. You have the culture. And you have to work across boundaries. If you're talking about person or people-centered healthcare, it has to be driven by persons and the community. And the patients have to be included right at the outset, not at the end when you have an adverse event. They have recommendations with regard to creating vision and building the will, recommendations on developing capability, recommendations on delivering results, and shaping culture and engagement across boundaries. So I'd like to come to our local setting. How are we faring? And for that, I looked at the quality of primary care in the Harvard report, which was presented to the Health Ministry, I think in March 2016. The primary care doctors were not identified as the first point of contact. And doctors in public clinics were not deeply involved in comprehensive follow-up of a wide range of primary care sensitive conditions. The continuity of care between specialists and primary care providers is weak. Medical officers do not regularly carry out many medical and surgical procedures which a primary care practice should be carrying out. They also look at the quality of secondary and tertiary care, and they were limited by data from public hospitals. Of course, almost no data from private hospitals. But they found that the 30-day mortality for acute myocardial infarction and stroke was high in 2008 compared to OECD countries. But this improved tremendously in a decade. So much so that it was approaching OECD countries' data at the end of that decade. And cataract day surgery increased from 29% to 52% in MOH hospitals in 2012 and 2013, compared to 83% in OECD countries. They also look at allocative efficiency. Now, what is very disturbing is that 49% of total healthcare expenditure is spent on secondary care and only 17% on primary care, when the figure should be the other way around, and very little on long-term care. The shift of expenditure towards secondary and tertiary care was marked between 1997 and 2013. The real expenditure per capita on secondary and tertiary care increased by 130% during this period, whereas that on primary care, only 73%. I think this is an objective lesson for all of us. We are putting our money where we shouldn't be. We are not putting our money where it should be. There's a high share of hospital admissions for ambulatory care sensitive conditions and a very high rate of admissions to hospital for long-term complications of diabetes. There's a movement. Sorry. They look also at technical efficiency, and they were supposed to come out with a health facility costing study. We have yet to find this report in the public domain. Perhaps the OSA can be lifted on this report and it can find it into the public domain so that the stakeholders can discuss this matter and maybe offer suggestions on how to improve things. But what is also very disturbing is the public sector procurement prices for medicines were 3 to 4 times the corresponding international reference pricing So the public sector were purchasing medicines at much higher prices than some of the private healthcare facilities. In their concluding remarks, they said that the Malaysian healthcare system is at a crossroads. It faces new challenges, and in effect, Malaysia demonstrates a classic case of asymmetric transition, where the rapid transition in contexts have not been matched with a corresponding transition in the health system to better address the current and future needs of the population. Give me 3 minutes. Now I'll come to the Private Healthcare Facilities and Services Act. There are provisions for all these conditions, these requirements, but there are no reports. Question is, why? There are also legal provisions for the DG to issue directives on quality. I work in a private hospital, and I have sat also in private hospital boards. But to date, I've not heard of any directives from the Ministry of Health. Question, why? There's also provision that healthcare management should be in the hands of the practitioner. The practitioners have complained of interference by third parties to the MOH over the past decade or so or more, but there has been no response. The Patient Safety Council was established in 2003, it came out with its patient safety goals in 2013 and started electronic incident reporting and then patient safety awareness course for house officers in 2017. There is, however, no data that the patient safety has improved since 2003. I make no apologies for putting this slide up. This came out, I think, in the news in June last year on the JB Hospital fire. And the chairman of the committee requested that the findings be made public. This was the statement by the minister. I wish he was here. The deputy is here anyway. He can pass the message. He stated in November last year that it has to be presented to Cabinet first. We have still not seen the report in the public domain. This is now March 2019. So have we got to wait until June before something is done about it? Now, this is not in your handout. I only got this put in yesterday night. And this is an English language online survey done by the Galen Center, which came out on the 4th of this month. You can access the report on their website. There were 242 responses, of which 46% were patients and 12% were caregivers. The question posed to them was, what matters to Malaysians in healthcare? This is a quick summary of their responses. Shorter wait times at hospital, cheaper treatments, etc. And this was what they wrote about public hospitals and private hospitals. You can see for the private hospitals, it's all about money until right at the bottom. For the public hospitals, it's waiting time. So I think we can learn from others. The Mid Staffordshire Public Inquiry made several recommendations. And these are a summary of those recommendations. I'd like to quote what Robert Francis stated in his report. The NHS and all who work for it must adopt and demonstrate a shared culture in which the patient is the priority in everything done. This requires leadership at all levels, from the ward to the top of the Department of Health, committed to and capable of involving all staff with those values and standards. Of course, I always like to refer to what my colleagues have stated, and David Evans, a consultant in Northumbria, wrote in 2015, the training of people to lead and manage only works if you have got a system that allows them to do that and supports them in the decisions they make. People see the value in this because we have put in place a very clear structure it's not only doctors who lead the services. We have psychologists, therapists, and midwives running our services and doing it very well. Now, the Plaintree body organization in the United States have come out with a list of myths of patient-centered care, and I would like to commend that to your reading when you get the handout from the organizers. So my last remarks, is that high-impact leadership is required at all levels in a care delivery organization in order to deliver results. My question is there political will and leadership in Malaysian healthcare organizations to put patients at the heart of healthcare? Thank you very much for your attention.
Okay, thank you, Milton. There's a very comprehensive presentation. It's excellent. I'd just like to urge all of you to look up two things from his presentation. I hope you look at his presentation in detail, but two things he mentioned there. One is the Institute of Healthcare Improvement, referred to as IHI, and the triple aim. Okay, to me that's important to understand. And the other one is to look up Plaintree. He referred to a paper by Susan Frampton, who is the CEO of Plaintree. Plaintree, the whole work, is a not-for-profit organization in the US. They work for patient-centered care. And it's very interesting the work that they're doing. Because in Malaysia now, KPJ has 2 hospitals that they're certified as patient-centered. So you can try that out and see, is it truly patient-centered or not, and give feedback to them. Okay, thank you. Now can I invite Dato Kuljit Singh?
Thank you. Okay, thank you very much, Tan Sri Abu Bakar, and thank you to the organizers to invite me to speak at this forum. Okay, first and foremost, I'm not going to use any slides. It's very, not me of not using slides. I love using slides. But I thought since I'm going to be the last batsman, I'm not going to go into the technicalities that you have already got the technical information, and I don't want to repeat it again. Let me just speak directly as the president of the Association of Private Hospitals. Now, it is a tradition in Malaysia, I would say tradition, that if you're a baby boomer, if you're coming from a baby boomer era, we expect healthcare to be absolutely free because we have been brought up with that kind of generation. But if you're a millennial, it's a little bit different. Most likely the millennials do not know anything, what cost is about, what value is, probably. Probably some will beg to differ. We expect, when I say we Malaysians, we expect high value in our healthcare. When we go to a doctor, we expect high value, but we are not willing to pay. We're willing to have high value, but we want it at low cost or no cost. We want faster care. Waiting for a doctor for an hour and getting out of the hospital to see the doctor get a medication which sometimes encompasses half day is not acceptable. And it should be accessible. The hospital, the clinic should be so close to your working place that you need not go through a traffic jam. That is what our expectations are, and that's what Malaysians in general will expect. But having said that, all of these things cannot come without a cost. So private hospitals, when you see a doctor in a private hospital, we do provide you very well quoted like the speakers earlier, patient-centered care is there in private hospitals. But that is natural. When you pay for something, immediately your customer, your client or your patient here will expect the value. Immediately. Patients leave the hospital. The last chain, the food chain in the hospital is paying the doctor's bill, the hospital bill. Then you get your medication and go out of the hospital. And the first thing that occurs in their mind is, did I get the value of what I paid for? regardless even if the insurance is paying for it, they do think back, was it a valuable experience or did I get, that's the mindset of any one of us. You buy anything, you will always think that way because you pay from your pocket. But when something is given free to you, and then it is pretty natural that you don't have that kind of value in your mind because it was free. In the private setting, it is very much, patient is already the center point because that they become clients more than a patient. They can choose their specialty, they can choose their specialist. They have got the avenue of discussion with the specialist, with the particular healthcare provider. Electronic medical records helps to make the patient the center point. Because electronic medical records, if you do not have that, it doesn't move anywhere better than treating the patient holistically. For example, if you see a patient in a private setting when you have an electronic medical record, the treating doctors have got accessibility to the entire record of the patient, not just in that particular specialty, but in the other areas too. So in that manner, the patient-centered healthcare actually helps. The patient feels that he's been treated at a faster rate and in a bit more accuracy. Now, electronic medical record now goes to another paradigm that is called artificial intelligence. The world is talking about artificial intelligence. Healthcare is already into artificial intelligence and is going to get probably fully into artificial intelligence in the next 5 years, if not earlier. And that's where we should start thinking that to have the patient as a center point, artificial intelligence is going to be the next thing that we need to have. Are we still going to sit on written records and stick to our old way of doing things? Then it'll never be patient-centered care. Patients come to us with total amount of information that they can get from the media, from the Google. They can Google anything that they want. They have got the information. But are we, as healthcare providers, ready for it? Now, all of this comes with a cost. Now, cost is quite a subjective thing. You run a hospital, you run a private hospital. Most private hospitals, I'll always say this in many forums, the cost that goes into running a private hospital is actually very expensive. But comparatively speaking to our neighboring countries, we are still much cheaper. But we should also realize the payouts that the patient can give, the potential amount of money that they can pay. In our society, you have got a very low level of affordability when you compare to other parts of our region. So it is basically a tough call when you do try to give medical care at a certain level because the cost escalates. Private hospitals will try to reduce the cost, but they try to get the margins from the patient in terms of the medication, treatment, care, and sometimes that becomes very unacceptable to the patient. Coming back to what I said earlier, patient always expects good care at a low cost. How do we move forward? There are two ways we can move forward in order to fulfill the requirement of the topic today. Public and private partnership has always been a topic for the last 10 years as I can remember, but it never gets crystallized because there are no commitments on both parties, public and the private sector. If there is a commitment and they can sit together, then you will find that the private sector can actually help the rest of the group of people who cannot afford private healthcare, but the government can come in to help this group of patients to use the resources in the private sector. But the most important thing to make this private and public partnership work is a robust healthcare financing system. If you cannot get that in place, then the formula will never work out. We can speak, we can talk, but that will never. When I say robust healthcare financing system, it should be a system that is sustainable. It cannot be a one-off thing for the next 4 years, next 5 years, and then there is no plan henceforth. Then it will not work. So looking at all this, if you want to look at value-based healthcare and putting the patient at the healthcare, that would be the way forward, using technology, artificial intelligence, public and private partnership, and again, a good healthcare financing system that will be sustainable. So that's my take on this topic, and probably we can discuss more on it. So I give you more time that we can interact and we can discuss that in that manner. Thank you.
Thank you, Kuljit. Okay, you've heard from all of them. I would like comments and questions from all of you. But perhaps I will just pose one question to these two doctors here. They have both worked in the government and they're now in the private sector. Now, tell the forum here, which is cheaper to the patient? And when I talk to the patient, I'm talking about the cost of care. The public or the private sector? Milton first.
I would like to make a distinction between cost and price. Cost is the expenditure needed to produce a product or a service, whereas price is what you pay for it. In the public sector, everybody who goes there pays a token sum. But that is not the actual cost. The cost is much more than that. The cost is borne by the taxpayer. Whereas in the private sector, the patient or the family or the payer has to pay an amount that is needed for the hospital or clinic to produce a service, plus the professional fees, plus the profit margin that the hospital in particular has set itself. Most private hospitals, they tell me, have a return of something like 7, 8, 9% per annum. Although there were at one time an instruction to get a 25% return, which was very, very high target. Let's put it this way.
Yeah, in my opinion, I mean, like what Tan Sri said, I have worked in the Ministry of Health Hospital in KKM, and I also worked in a university hospital, and now in private hospital. I worked in 3 different sectors. They're all different. But I believe when I look at costing, now I am the medical director of my hospital, and I can also look at costing. And I think that there should be a lot of thought should be given to the public sector, whether are they really spending the correct amount of money on what they are actually providing to the rakyat. If they really tweak their expenditure, I am quite confident that they would probably save a lot and actually provide more to the rakyat. They can just engage some of the private hospital providers to sit with them, and they can actually show how they make their hospitals profitable to about 7 or 8%. I think there is some restructuring that may be needed. I'm not an economist. I'm not a healthcare finance kind of an expert. But from my view, on simple things, when you go for procurement of equipment and things, they are actually priced pretty much different, unless you challenge me and say it's not true. Just on the simple thing, I mean, I'm just talking about my specialty. These are the minor things that you do that I'm sure that you will get a better figure end of the day, and it will be more sustainable. My personal view on this.
Thank you. Well, the reality is like this. We know the cost in the private sector because there's greater transparency in trying to calculate the cost. In the government sector, it's a lot more difficult because the hidden costs are just so huge. The hidden costs may be double or more what the calculated costs from the, let's say, from the public sector. Although for the studies, there are formula to estimate the hidden costs. But just to give you an example, in 1992, I think, the Ministry of Health did a study with the World Bank on the cost of services by the GP and outpatient department in Penang. The GP cost was so much cheaper. So I remember when it came to me, I was saying, if this is the case, why are we running the outpatient department in the hospital? More realistic for the GPs to run it. Okay. I mean, what I'm trying to say, the cost and Milton say, and the price are two different things actually, you know, because nobody wants to invest in a hospital which is so expensive unless they can make it pay for itself. So if you look at the history in Malaysia, the first few private hospitals in Malaysia were actually funded by doctors. Pantai, Johor Bahru, I was involved there, the first KPJ hospital, and Ipoh and Penang. Yeah. They were all started by doctors. Once it was shown that the model can work, then the other investors come in. So what I'm talking about here, cost is relative. There must be a return to it. Otherwise, it is not, people will not invest. Let me give you another perspective. 1985, the government did the first health financing study. Malaysia spent 1.8% of GDP on health. 1985. The most recent study by Harvard is about 4% of GDP on health, roughly. So if you look then, in about the 30 years difference, we've increased the spending on health and healthcare a lot, from 1.8% to over 4%, at a time when the GDP has been growing at least 6 to 7% every year. It's been a huge investment in healthcare. So what value are we getting? So if we look at the data in the last century, Malaysia did very well. We got good value. But as the minister said, in this century, good, but not nearly so good. We have to do better. Okay, now just to relay what you have done and what the minister had mentioned in his speech just now. Now, can I have questions and comments, please? Wow, what's happened? Please, thank you.
Hello, yes. Thank you for the enlightenment. Here I have a questions to pose that is regarding with the public insurance, especially for the M40. How to justify the kind of value to the patients that is in terms of solving the problem, the well-being of the patients, as well as to avoid the unnecessary leakages. And from a public point of view, is how government is justified the way the resources are used effectively between the public and the private in terms of this insurance scheme is introduced. Thirdly is on the issue of lobbying. As we know, public insurance involves a lot of lobby, and how that will be justified to ensure we do not repeat the past histories that has been introduced in many other countries. Thank you.
No, we don't have public health insurance. Oh, okay. No, wait. Okay, first is the insurance. Can I invite the comment from Milton first?
I must say I only worked 2 years and 3 weeks in the Ministry of Health. And that was a long time ago. I mean, although I was in NHS for quite some time. But I think you could look at insurance this way. Whether it is social insurance or whether it's commercial insurance, I think there is a difference between the two. the basis for insurance, whether social or commercial, is risk sharing. The young support the old, the healthy support the not so healthy. Commercial insurance is a little bit different. There is an element of return to shareholders, which you don't find in social insurance. I cannot explain my salam or peka or pekak. I call it pekak to my colleagues tell me it's pekak. Because I think that answer has to be provided by the respective ministries. But can I just give one or two more sentences? But whatever it is, there has to be clarity on the operationalization of both My Salam and Bakar. Simply because the person on the ground or the B40 should know what is the process, what are exceptions you find in commercial insurance, but if it's a social protection, then there shouldn't be any exceptions. Because, it's kind of difficult for a doctor in a clinic to decide when the diabetes started or when the hypertension started. But commercial insurance, they always ask the doctor to state whether this was a pre-existing condition and how many months before the insurance policy was taken, before whether the conditions was existing before the insurance policy was taken. So I'll leave it to the regulators to answer that question.
Okay, thank you for the question. What I can say is PECA for B40 and My Salam complement each other. PECA is the assistance given to the B40 groups who are more than 50 years old. This is for screening and also for assistive medical device, which includes implants and all that to help them. And also, they give 1,000 ringgit for those who complete their cancer treatment. This is only to assist those people in the B40 group who are more than 50. And my PECA is under Ministry of Health, whereas My Salam is under Ministry of Finance. Okay, I cannot comment much on My Salam. Okay, but this is an insurance scheme, risk sharing to help those in the B40 group. Yeah? Because this B40 is the group that need help financially. If they have these chronic diseases, it's going to be a problem to them, okay, to continue because it's very expensive. If they have a cancer, even those in the M40 groups, if you have cancer treatment and you do have insurance, you go to private sector for treatment, maybe it can be devastating for you because of the cost of the treatment is very high. Is to help them. Okay, I think that's all that I can say about PECA and B40.
That's
okay. Thank you.
Just one comment. My only comment is I don't expect an answer for this, but this scheme, I hope, my hope, because I got friends who are also in the B40 group, friends. Though some people may regard us being in the private as the fat cat or the Garfield, we are not. We also have friends in B40. And what my worry is, again personal worry, I hope it's not a one-off thing. That means come 5 years, funds over, the program is over and then they are back to square one. That's my worry. It should be something that is sustainable and it should continue. It should not just be for the next 5 years and then funds are over, story is over. That is personal worry.
Okay. In terms of your question about health insurance, what Dr. Milton has mentioned, social insurance is pooling of risk and pooling of funds. And nobody is actually, left out. Everybody is included. But private insurance is risk rated. The moment you got illness, got disability, and you get older, then they leave you out. So that's a major difference, And in Malaysia, the amount of people with health insurance is quite small. Most of them are actually group insurance from employers. And the other one is your whole life policy. They give you something on health as a benefit. So the coverage is actually fairly limited, So just to clarify that point, to cover your question. Now, I think about My Salam and Bakar P40. Okay, what is so good about it? What is good about it is, hey, something has started. We have made a bold step forward. That's wonderful. It's not the solution. We got to work towards the solution. We got to put in other components in place. As Kuljit mentioned, My Salam, I spoke to somebody from Great Eastern. My impression is, okay, there is an element of financial risk protection. I think that is good. Right? But they did it such that it brings the business back to Great Eastern. Well, why should we be surprised? So after 5 years, as mentioned, how do we continue? Well, I'm sure Treasury will continue to work at it. It's just a step, Now for Bakar P40, it's actually for the health screening part. I think it's very important. There will be improvements in the future. We got to check with SOXO. SOXO also got the vouchers for health screening. Why are the people not using it? So I think what the message here is, you can have the resource, but how do we get the people to have the right behavior to actually make use of it? Now, that's something that we all have to work on.
Being or the patient, including the family, where if the insurance concept is involved, as what we have witnessed in our daily life in Malaysia, those private hospitals in the list, including doctors, where we know we have insurance scheme, and a lot of unnecessary investigation, including high costs, will be imposed, and that is the reality. And it does not constitute any benefit to either the patient, the family, nor the country. So how could the government impose law to justify the concept of insurance that ensure the well-being that is called the value, under the value healthcare concept going to be implemented in Malaysia? I seek enlightenment from the panel. Thank you.
Okay, thank you very much. But I think, can the moderator of the session on health financing take up that question for that panel? Okay? No, because you want to input? Yeah, go ahead. No.
Okay. Even if it's private insurance, they have certain regulations that they have to follow. We have under our Private and Healthcare Facility Act, there is a fee schedule. Okay, usually only procedures listed under the fee schedule will be reimbursed by the insurance company. If there are new technologies where the insurance company are not sure whether they should reimburse or not, usually they will refer to us. They will ask Ministry of Health and our Health Technology Assessment section whether this technology is being recognized by Ministry of Health and should they actually reimburse the patients for the treatment. So there is some actually regulations, methods on how to control the treatment received by the patients to avoid the unnecessary treatment. Okay, thank you very much.
No, okay. But a simple way of looking at it is, we need an indicator for appropriateness. That is missing. No matter how much regulation you put in, everybody will game the system. Kwan Ju, just relax, huh? You can take up that question to your panel later this afternoon. Last question. Huh?
It's not a question. I think I'd rather like to make a comment on the Bakar B40 I think it's very important. I don't know how many of people here, participants here, are aware of this program called COSPAN, that is Community Sehat Perkasa Negara. All right? And this was started in 2013. And this is a community-based screening program. And there was one pilot project that was done in 26. You see, the community centers were these internet centers in the community where the volunteers were trained to do the screening, that is taking the weight, calculating the BMI, and taking the blood and doing the blood sugar and for screening. And in a pilot project in Selangor, 26 centers were identified, and in the period of 6 months, 4,000 over people were screened, of which 2,000 over were referred for some problems. So you can see it's about 50% of the population screened had some problem or the other, like obesity or hypercholesterolemia or diabetic, blood sugar above 5.6. All right. So I think this is the reason why the PKB40 has been brought up. But COSPAN is community-based, but I think the general practitioners have been asking the government, bring this public-private initiative, all right? And so get the general practitioners, 7,000, now it's 9,000 clinics, private clinics throughout the country, according to the data of December 2018, and get them involved. So the basis for the PKB40 is this pilot study that has shown, but 50% of this population has some form of indicator for NCD. I think, as Tan Sri said, we have to start somewhere, and I think it's a good move, though the general practitioners have problems with the other aspects. But I think we can go, we can tweak along we can tweak the process as we go along. But I think it is a good initiative, and I think this if it continues, now it is 800,000 people, but there are about 3 million to be covered at a later stage, and if it can be continued, it will be good. But coming to this insurance, I think we do need a health financing reform very, very badly in our country. 39% of out-of-pocket payment is not sustainable. All right, so we do need. I think Dr. Lim Kuan Chu's team will address this later in the afternoon. Thank you very much.
Thank you. That's Dr. Namazi. He's the president of the Malaysian Medical Association. Thank you, Namazi. I think the point he's making is very important. What happens at the community level is critically important, And I think trying to get platforms at the community level for them to manage their health as well as their care is very important. That's why I mentioned about the patient-centered medical homes in the US, whereby everybody gets together to manage their health. I think just now, the Minister of Health talked to us about Cuba. If any of you visit Cuba, as I have, and I visited the health clinics there, one doctor looks after 70 or 80 families. And all the records of the families are there with him, and he showed it to them. And they're managing not just the care, but also the health, in terms of health promotion, disease prevention, and early detection. So I think that's what we got to go forward, going forward. We got to go not just at the hospital, we got to move away, because hospitals are going to be intensive care, step-down care. So much can be done outside the hospital. Okay, ladies and gentlemen, I think we've used up our time. I would like to thank our very sporting panel members for their contribution, and thank all of you for your participation.